Hello, students. Today we'll discuss an important topic uh, in brief, probably, that is management of oral cancer. I'm here discussing concepts basically and current trends. So that is important. Often it is very difficult. And remember, oral cancers are most common malignancies which we come across in India, especially in the South India. Lot of problems, morbidity, mortality. We'll see when you manage or when you see oral cancers. So it's important to know basics and concepts and current changing trends also about managing oral cancer. Or just see that. So I'm going to discuss initial evaluation, staging, factors affecting the management principles. So all these headings I'll discuss about the oral cancer. So initial evaluation how to do. I'm not going to discuss clinical features. All of you know that ulcer will be there, smoking history, 6x, 5, 6 yes, spirit, smoking, sharp teeth, and all those things I'm not going to discuss. And pathology commonly is squamous cell carcinoma and buccal mucosa, tongue, common area, floor of the mouth it can occur, posterior of the tongue it can occur, palate, other areas also it can occur. Often it is synchronous, many places it can occur. Mitochondrial disease also known to occur in the oral malignancy. Human papilloma virus, HPV, and Epstein-Barr virus may be the causative agent, especially in the oropharyngeal HPV and nasopharyngeal EBV. All those things, basic concepts. I'm not going to straight away going to the discussion of the management aspect as such. So evaluation, what is most important is when you take a wedge biopsy, not the edge biopsy, the wedge biopsy from the edge of the ulcer, at least a minimum 2 biopsy is you have to take. And what you have to look for is grading, histological nature, type of malignancy, naturally it is a squamous cell carcinoma, and depth of invasion. There is a current trend. Now there is a difference between the tumor thickness and depth of invasion. Tumor thickness is from the surface of the tumor to the depth, how far deep it has gone. Whereas the depth of invasion is from the basement to the depth. So naturally it gives the idea about the growth, which is how much going inside. So exophytic growths will have a less depth of invasion. Growth which is going inside, endophytic, those growths will have more depth of invasion. This factor is very important because depth of invasion in relation to the basement membrane makes the outcome difference. If there is more depth of invasion, lymph node involvement is more likely, and spread is more likely, and outcome will be comparable to the less depth of invasion will be poorer. So that is why this is the most important factor which you have to remember, depth of invasion. This is the most important factor. So imaging, again, basically initially ultrasound neck you have to do, then CCT is a must to identify the primary tumor, how far it is extending, posterior extension, deeper extension, local stages, mainly T4 lesions, size, extension becomes T3, T1, 2, 3, 4, especially 4A, where it is extending, soft tissues, bone involvement, mandible involvement, or maxilla involvement, depending on the location, floor of the mouth. Crossing the midline makes a lot of difference because if it crosses the midline, surgical approach is difficult and overall outcome is not good. So assessment of the primary tumor as well as the neck and chest. Chest commonly it is the bronchopneumonia it occurs, but in a patient who is immunosuppressor, old people, they can have a metastatic disease of the squamous cell carcinoma to the lung. So otherwise, commonly they are loco-regional disease, means primary tumor with neck lymph node spread in or involvement. So MRI is different. MRI and CCT is complementary to each other. It is not which one investigation, it's nothing like that. If it is needed, you have to do MRI, do CT scan first, contrast enhanced CT, then assess everything. If you have to do MRI to that particular patient, then you have to go ahead, especially when you look into the soft tissue delineation, marrow, especially mandible marrow involvement, whether it is infratemporal fossa, pterygotemporal fossa, base of the skull involvement, floor of the mouth, alveolar margin, all these things are important when you assess. So MRI is a very crucial marker to say about all these concepts because you whether you have a base of skull approach, how much you can be able to clear, whether you give neoadjuvant therapy initially, then go for the surgery, depending on the response, then how adjuvant therapy, what chemotherapy we'll give. All those things definitely will have the idea to decide based on these factors. So MRI definitely has got a valid investigation along with the CECT. So PET-CT mainly done only in stage 3 and 4, not in every patient. When you do that, especially pharyngeal axis is very well assessed with the PET-CT compared to other investigation. Stage 3, 4, because other organ, lung, everything can be assessed. Recurrent tumors, PET-CT is essential. So these are different, the indications for PET-CT. So grading, old grading, although if you know that Broder's grading, well differentiated based on the keratin pulse, epithelial pulse, moderately differentiated, poorly differentiated, very poorly differentiated, grade 1, 2, 3, 4. That is based on the whether it is keratin pulse are more than 75% or 50 to 75% or 25 to 50% or less than 25%. If it is less than 25%, it is poorly differentiated. Otherwise, keratin pulse, if there is more in number, it gives a good prognosis or it is well differentiated. And present grading systems, G, GX, G1, 2, 3. There are newer grading systems also there. I'm going to discuss that because current trend also important for us. It's not the final. There are a lot of shortcomings. Pathologists say that about this Broder's grading and G grading. So other grading I will tell anyway. But orthopentagonogram, good old investigations is there. It gives a view, a straight line view of the mandible to see the involvement, outer table, inner table, dentition, everything. But currently this investigation is replaced by proper CECT head and neck. So this is the old investigation, remember. So ultrasound guided FNAC of the node is a must. We'll never do open biopsy for the lymph node unless it is fungated, unless repeated FNAC investigation comes negative. We think clinically that it is involved and there is a specified oral primary tumor. So orthopedic, I already told, examination under anesthesia. General anesthesia, you have to assess, you have to feel the tumor, you have to feel the extent, floor of the mouth, other area of the oral cavity. So that's also very important point in assessing the tumors, very important before planning for surgery. That's a very crucial investigation. So this is the Brian's histological grading and scoring system. Additional things are degree of keratinization, nuclear pleomorphism, number of mitosis, pattern of invasion. This is very, very important. Different patterns, score. You look at that. Pushing type, infiltrating type, small groups infiltrating, marked widespread. So 1, 2, 3, 4 are there. Lymphoplasmacytic infiltration is also important. So all these scores are there, 1, 2, 3, 4, then different degrees. Total scores are there. That is how it is being graded. Grade 1, grade 2, grade 3. So final score comes like this, much, much better than good old Broder's grading. Because a lot of information, many information about this. So Brian's grading is very similar. Different grading systems are there, but this is better grading system compared to, enough studies have told that this is better grading compared to Broder grading, even though clinicians depend mostly on the Broder grading, but gives a lot more informations. So Brian's grading, that's important. So this is the different studies how Brian's grading is more important, more specification than the other grading system. So again, see that, look at that, Brian's grading system, different grading. So Brian's grading system appears to be the best in predicting the outcome of this squamous cell carcinoma. So it is very clearly, see that, very clearly mentioned. It gives the best outcome. Different studies have shown that. And see that, how to do that, FNAC guided aspiration, lymph node you can see here, lymph node you can see that FNAC. So it's very diagnostic. You can always see CT, you can see the CT here, node is there. See that primary tumor is there, MRI gives a better sometimes. Tissue delineation gives better. Lymph node, CT scan is better. That's the point you have to remember. So both are complementary to each other. It's not only one you will do. When you do CCT, if you feel that MRI needed, should do it. So PET-CT I already told 3 and 4 and recurrent disease or residual diseases. That's how it looks. Now there are newer diagnostic modalities and many setup may not be available, but it becomes the current trend. See that oral brush biopsy, toluidine blue, light-based detection system, all those newer things, biomarkers. Eventually it will come into the picture. Many big onco centers, not in usual centers, they started doing these things. So we will be able to get a better histological evidence before planning for surgery. Also, we'll be able to give a diagnosis before it becomes a late stage. So early diagnosis is very important. Early detection gives, and second thing is histological evidence. You will have a better by these newer modalities of early detection of cancer is very, very important, especially in the oral cavity, so that you will get a cure. Outcome is very good. Morbidity and mortality is prevented, and all this is the different. You can see that tolerant rule application, how it stained mucosa, so that malignancy you can take a specification biopsy. This is the well scope. This is the scope there. It gives a very clear picture. So this is the well scope autofluorescence. See that fluorescence, you can see how abnormal and normal looks like. So this is the normal, this is the abnormal. See that abnormal cells here. See that tumor. You can see that tumor, this one very easily. So then you can take a specific biopsy. You can hit like this directly here. You are through. Otherwise, if you take a biopsy from here, you will not be able to get a positive histological evidence. So again, another thing, same thing, different method, chemiluminescence vigilate, same thing. Collodium blue staining, look at that, how mucosa stain, and you can identify the growth here. So SLNB is again, even though it is very commonly used in melanoma, carcinoma breast, and carcinoma penis, for the three areas. Now SLNB has become widespread and becoming more and more. They started doing it. One of the areas is oral cancer, where you can inject dye, or whatever, radioactive dye or toluene blue dye, whatever, or dye, visual dye, whatever used for other areas. Then identify the lymph node. Then see that you can see that lymph node here, fluorescence. You can see that, and then mark it and remove the lymph node for histopathological evidence. So it's still be becoming popular and popular in oral cancer, which is already accepted well in carcinoma breast, melanoma, and carcinoma penis. So this is the most important thing. Now currently, so many oral malignancies other than whatever is smoking, pan chewing, and all those alcohol, all those things. Other than that, in many patients, you can see non-smoker, those who are not taking tobacco also, they get oral malignancy. Top is an younger individual, that is human papilloma virus infection. So that is really quite common in the oropharyngeal cancer. So human papilloma virus, oral carcinoma, it is very well related now. See what exactly it is. HPV-16, this is the MCQ question, remember, is the main causative agent. For oropharyngeal cancer. Affects both males and females, common in males. Pap smear detection possible. HPV DNA is there. HPV vaccines are there. There's a different vaccine to protect human papilloma virus. And see that favorable prognosis compared to HPV negative. So even though it is a causative agent, it can occur in non-smoker and other areas, but this has got a better prognosis compared to the patient who is having non-HPV malignancies. That is due to pan chewing, tobacco, smoking, alcohol, and so on. So HPV-16 is the main agent, and oropharyngeal cancer. That is important thing which you have to remember. And staging, I am not going to detail this one. All books I mentioned, white tissue involvement, T1, T2, 3. So what is important is depth of invasion, then tumor thickness. This is the most important, depth of invasion. So depth of invasion is most important. See that I already told the difference in the basement membrane depth it is. So depth of not tumor thickness, there is a difference. So this is the diagram which shows what is the meaning of depth of invasion. Nodal staging is important. See that all these things are N0, N1. Extranodal extension is the most important thing you have to remember. It's very crucial. So makes the difference. Planning the surgery, planning the therapy, deciding the outcome. Everything is Western extension is very important. And in the number of node involvement, that's also important. So decisive factors are end staging, extranodal extension, number of node involvement. The 3 points in the nodes is very crucial to which will have a very valid relation to have an outcome. So factors affecting the management, tumor factors, patient factor, physician factor or team factor. So tumor factors are, all these things are primary site, size, location. Anterior tumor has got a better prognosis than the posterior because anterior is visible, they present early. and your surgical approach is easier. If diagnosed early, surgical approach is easier and reconstruction is easier. So outcome is better. Proximity to the bone, close to the bone, outcome is poor because of mandible extension, maxilla extension. Status, this is the most important thing I already told. And previous treatment, recurrent disease, previous treated not properly, this will make a lot of difference. Depth of innovation is most important histologically. That is I already told. Patient factors, so all these things are important. Age, younger age group, poor prognosis, general medical condition, tolerance to treatment, diabetes, hypertension, immunosuppression, all those things make a lot of difference. Other diseases, occupation of the patient, acceptance and compliance, lifestyle, smoking, drinking, and socio-economic concerns is very important too, because treatment strategy is very costly. Treatment strategy is very long term. May require at least more than a year to complete the treatment. Neoadjuvant, surgery, then adjuvant, then further evaluation, further treatment, and regular, with a lot of cost factor and time duration. Regularly they have to come, they lose a job, they can't go for work, family members are to attend with the patient. So all these things are very important factors in this patient. Physician factor, again surgery, radiotherapy, it's a team important. All these things are important. It's a team approach, not one person. Surgeon, physician, rehabilitation, psychologist, psychotherapist, everything. So treatment strategy, surgery is the mainstay. When it is operable, radiotherapy, chemotherapy, all these three modalities, not much. Hormone therapy, not much, remember. Targeted therapy may be there. Sometimes targeted therapy definitely is important. And chemoradiotherapy, neoadjuvant therapy, that's in stage 2, 3 especially, when initially you are not operating, give neoadjuvant chemotherapy or neoadjuvant chemoradiotherapy, mainly chemoradiotherapy. So downstage the tumor and make it operable, and then do the surgery, then continue with the adjuvant therapy. So this is very important, especially in stage 2 late or stage 3. Concurrent chemoradiotherapy is very effective. Chemo will sensitize the radiation. Radiotherapy will sensitize the chemotherapy. So that's again important. Palliative therapy, nothing is possible. Rather stage 4 disease, inoperable, and give palliation, swallowing, bleeding, infection, quality, little bit better quality, not complete quality of life. So there's only palliative, outcome is not good, outcome is not assessed at all in this. So all these different methods we'll use to treat the patient. So targeted therapy is, again, I already told, this is also sometimes you may use, not very commonly, but many times it may be useful. So mode of treatment, I already told, surgery, radiotherapy, chemotherapy. Intra-arterial IV also can be given. Curative, all the things are there in detail, whatever I discussed. Note, treatment may be curative or palliative. So early growth without bone involvement, all these things are possible. Curative, radiotherapy initially, wide local excision, growth with mandible involvement, do wide local excision, sometimes segmental mandibulectomy, marginal mandibulectomy, that part of the mandible, or sometimes extensive involvement, hemimandibulectomy. Olden days we used to do regularly, but currently it is not commonly done. Only marginal, segmental mandibulectomy, partial mandibulectomy, more than sufficient. And growth with the mandible, of already told, proper reconstruction is very, very important. So all these oral malignancies after surgery requires a proper reconstruction. Maybe commonly now, of course, free flaps, radial forearm or free flap, or tibial or fibular, not tibial, fibular free flaps. You use it so that with plates, of course, if you are removing the part of the mandible. So reconstruction is very important, valid approach. So operable growth with the mandible, with the neck, mobile neck, involved lymph nodes, then you have to do a neck dissection. Maybe modified radical neck dissection. What are the types? 1, 2, 3 are different types, but clear the lymph nodes, very important. If it's high grade, all levels has to be removed. Sometimes if it is attached to the sternocleidomastoid, that has to be removed. Then very close to the jugular, then jugular vein has to be removed. Most of the time, final accessory nerve is retained. Jugular vein and sternocleidomastoid muscle removal, among the types, is decided based on the number of nodes, closeness of the node to the area, and involvement. So muscle, if it is involved, has to be removed. That's how exactly we'll decide about which type you are going to do. And here, wide extension of the tumor, hemimandibulectomy or local, it is not, need not be hemimandible, whatever extent, segmental, partial, marginal, then neck dissection has to be done. So mobile if the same side without mandible involvement, then wide local excision, MRND, then chemotherapy to continue. Fixed primary tumor, advanced neck lymph node, then only palliative therapy. Palliative radiotherapy can give initially, then you can continue with the chemotherapy and other things. So post-operative radiotherapy is given for T3, T4 lesions, important. N2, N3 nodal to reduce recurrence to improve the prognosis. So that is important, remember. So this is important when you give post-operative T3, T4 lesions and N2, N3 nodal status to reduce recurrence and prognosis. So you have to give radiotherapy RT in post-operative. Opinion and help dentist is important. So because you remove the dental this one, so dental molding is important. Dental people have to do the reconstruction. Then you have to take the help of the reconstructive team, plastic surgeons help to reconstruct, decide the flap, free flap, all those things they will do. So it's a teamwork. You do the procedure, you do the neck dissection, then hand over to them, then dentist will come, they'll take this one. That is later, of course. So wherever it's a teamwork, many people are involved in the treatment strategy. Preferably in N0, in severe high-grade lesions, we may do prophylactic block dissection in N0 disease. Usually such situations you will do supraomohyoid dissection. When you do supraomohyoid dissection, if it is, we have to do frozen section biopsy. If it is involved, then go ahead with the MRND. So all these things are how it is involved and how you will go with the chemoradiotherapy, role of chemotherapy, why it is initial to downstage, all those things. I'm not going to detail it. You can always read it. All these things are, the concepts are important when you approach individual patient. This is important. So these things are definitely important to go ahead and plan and have an idea about how exactly for individual patient. So principles of ablative surgery. So all these things are the principle. Adequate access to the tumor. To HA2 negative tumor is very, very important. Oncological clearance is important. Avoid tumor disruption. That is very, very important. Again, you can't disrupt the tumor. Clearance is most important. Frozen section biopsy, wide excision versus compartment excision, depending on the location where you will do, you will decide about it. So this is all these things are the most important thing while do the surgery. Frozen section, why margin clearance is most clear, again crucial. Depth clearance also important. Margin clearance side like this is the margin clearance. This is the tumor, and this is the tumor like this. This is the depth clearance. So margin clearance, depth clearance, both are important when you treat such patient. This is different surgical approaches. Transoral, small lesion transorally. Otherwise, commonly it's a lift incision. This is a very good incision where you can have proper access. So if it is through oral cavity, if you are able to do it, but don't struggle, because very compact area, your hands will not go. You immediately split the lip and go ahead, and then you have very good assets. Decision for the lip is a very good cosmetic, very good incision. Not have much scar about that. Another is a Patterson approach, just make incision, raise the flap and remove it. And visor approach, this is like this, where like a visor, visor is a helmet part. This lower part is called as a visor. So like this, you reflect entire thing, so that your approach will be very good. That is not in a difficult case only we will do it. Extensive growth, very close to the posterior part, all those things. Otherwise, usual thing, lift split and transoral, mainly lift split. Very, very beautiful, useful approach actually. This is the PMF flap done actually for after more. This is the lift split. See the lift split incision, the PMF flap actually from the muscle taken. And see that this is the how it is covered. This is the hemimandibular. In olden days we used to do hemimandibulectomy. Now it is not done. This is the coverage with the PMF flap. And see that mandible, when you remove do the segment of the mandible, with the reconstruction is done using plates, screws and plates. So hemimandibular is not common, but incision, neck dissection also, wide excision, all those things different comps. Just want to show, picturize how to. This is the harvesting fibular flap actually. See that fibular free flap, and this is the forehead flap you can use. How exactly it is brought down, and see the deltopectoral flap based on this. It is a cutaneous flap. Remember, it's not the PMF flap. Petrologist major myocutaneous flap is myocutaneous flap. Deltopectoral flap is a cutaneous flap like this. From a second perforator, it comes like this, then it goes like this from here. It is not, many students get confused that they think that it is a myocutaneous flap. It is a skin and fascia raised, harvested from the pectoral and deltoid region like this. then put it like this. It's the cutaneous flap, remember, not myocutaneous flap. There's a point you have to remember. MR and the neck McPhee incision, the McPhee incision. You get different incisions are there. V incision, Z incision, all those things. I'm not going to detail it. Of course, individual surgeons will have their own fancy of using the different incisions. So intraoral, only small lesion here. And then of course, lip split. This is the typical lip split incision. And upper cheek, Weber-Ferguson incision. If growth is in the upper part, reflect like this, then you'll have very good SS. And different mandibulotomies here. This diagram shows different mandibulotomies. See that? So that mandibulotomy approach is a visor approach. Lift above and see like a visor. Then have an approach. See that different resections, marginal, segmental, partial, hemimandible, rim resection. All those things are the different resections you usually come across, and depending on the individual patient, depending on the involvement of the tumor, we do it. And see that marginal mandible is only like this. This is the segment, is very commonly done. And this is the partial mandible, where the corona process is removed, not the head of the mandible, only this much. This is the entire mandible, is not commonly done. Olden days we used to do that. Now commonly done is this one and this one, remember, this one and this one. These things are not commonly done now. We'll get away with this. Most of the time we'll be able to finish with this. And this is the how exactly we'll remove this picture very clearly says how exactly remove all these different concepts, marginal mandible, segmental mandible. And this is the composite resection. The T4 lesion, everything remove, mandible, primary tumor, neck dissection, everything remove properly with the proper incision. Here, this is the incision for the neck dissection, clear it properly. And then after that, reconstruction you do. So these are different methods of reconstruction. Look at that. Split skin graft, deltopetal flap, forehead flap, PMF flap is the myocutaneous. This is the cutaneous. This is the cutaneous, remember. Reconstruction of the mandible with the fibula or synthetic graft, already shown actually. Free flaps are becoming very, very popular now, free flaps. So all these things are the different reconstruction procedures which you have to remember, maybe asked in questions, remember, MCQs, theory, Viva, practical, because the whole case is a long case actually. For both UGs and PGs, you have to know. So these are the different flaps. Again, I'm not going to detail it. You can always read it. And this is the pictures of exactly we do. This is the typical radial forearm flap. See that? So after wide local excision, see that tongue is that is the neck dissection. This is the flap which is placed there. See how exactly it is done. So newer concepts, just the newer concepts, less invasive probably. Robotic surgeries have come in, now become popular in a center where everything is available. So that visualization, where the skill and approach, clarity of the dissection will be better, your clearance will be better for especially oropharyngeal lesions. Robotic assisted neck dissections, navigation system for the skull base is very, very useful. Now most of the skull based surgery is currently done using microscope and also with the navigation system. Otherwise, very difficult to assess and very difficult to clear the tumor once the tumor reaches to the base of the skull. So navigation system is very useful and it's used now. It's probably essential, mandatory to do when you approach base of skull without the difficulty. Transoral endoscopic ultrasonic surgery, also different approach and different newer things actually. So newer concept, remember, many times they be asked in the Viva or question, theory question. So traditional methods are already told. So transoral, these newer methods are becoming popular in an advanced setup where it is there. So cosmesis and clearance outcome will be better, but takes time. Training is important. Learning curve is there. All the things are the different things which you have to remember. So this is again, remember, robotic assisted neck dissection with a transaxillary and retroauricular approach. From the axilla go through and do a approach, so that no incision here, or from here make an incision and go through reach there and through robot instruments and do the dissection, so that there is no incision in front. It's cosmetically it's good, but it requires skill, requires robotic setup, teamwork, everything. Eventually it may become very popular. TARA it is called as in short form. Transaxillary retroauricular approach in head and neck cancer. So concept is important, supra-notch and infra-notch. T4 doesn't mean unsettable, what we think many times is acceptable. So a transaxial plane which crosses the mandibular notch, see that here, you can see the diagram, this is the transaxial plane. So this is called supra-notch, this is called an infra-notch, this area. So whatever the tumor here, even though it is a T4, local extensive, it is operable. Whereas whatever tumor here, it enters in the basal skull also, it becomes inoperable. So this is very important. So this line is very important, remember. This transaxial plane line to divide supranotch and infranotch. So infranotch is operable. That point you have to remember, supranotch not. And so this is the evidence for that, which is a very good result. This is the meaning of vestigator temporal space, all those anatomy. We can always go through different books, but it's important when you operate all these muscles, you have to know pterygoid muscle, temporalis muscle, then lateral pterygoid, medial pterygoid, masseter, because all these muscles will come across, should have very different spaces. Masticator space and temporal spaces are different. So involvement of these spaces makes a lot of difference in deciding and doing surgical techniques for skill. So all these spaces are important. Masticator, supranotch, infranotch meanings. So therapeutic, elective versus therapeutic is very controversial things. I'm not going to detail it. Difficulties in reconstructions, medullary defects, no dissection, complications of flaps, reconstruction surgery, sepsis, morbidity, needs tracheostomy and gastrostomy is very important. Also, in a big malignancy where your dissection is extensive, flap you put, and may not be able to breathe, and they will go for respiratory problem, sudden distress, and may lose the patient, life threatening. Best thing is do a diversion tracheostomy here. Keep it for a few weeks. When patient is okay, wean the tracheostomy. Most important decision, remember, tracheostomy saves the life, makes your thing easier, and patient will be comfortable. So all these cases, think tracheostomy to do. And feeding, nutrition also important. They can put a rice tube and do a nutrition. Next day only can start nutrition. That is difficult if you will then do a gastrostomy and feeding, because patient sometimes feels very difficult to keep night tube for a long time, because sometimes many weeks you have to put the rice tube because of the reconstruction flap there. So in such a situation, do a gastrostomy and feed them. They'll be very comfortable. You can have a very good nutrition, because nutrition is very, very important in this patient. Albumin, hemoglobin, and other nutritional support is important for better healing. So this is important. Sepsis control also important. So all those things are, you have to look into that in this managing, not just surgery. All those concepts, everything you have to think of when you do a surgery in this patient. And so involvement retromolar trigone, you know that behind the last molar in the ramus of the mandible anterior aspect, triangular area, because it got a pharyngeal lymphatic, so it connect to the pharyngeal nodes. It will be considered to be advanced. So wide luxation, you can do the surgery, but adjuvant therapy is important. Sometimes you have to get new adjuvant therapy, then do the surgery. So this involvement is important. Base of the skull, fixed nodes, opposite side, crossing the midline. So crossing all these things are most important decisive factors when you treat a patient, remember. And upper way, all this again, I'm not going to discuss. It's all airway obstruction, fistulas, problems, everything. So that is important to think of in managing this patient. Critical decisions, intent of treatment, whether in a given patient after proper assessment, whether it's curative or palliative, modality, whether surgical or non-surgical, radiotherapy, chemotherapy, chemoradiotherapy, or radiotherapy plus chemo, all those things. And need for addressing neck in a clinically node negative patient. So whether you do maybe high grade T4 lesion, if there are no nodes, even then we promo head, then frozen section, then go ahead with the MRND. So that is important. So grading may be different. Grading and staging of the T4 T lesion makes you to take a call about doing the neck dissection. I prefer to do neck dissection in a large tumor with the high grade, because eventually node involvement is very common. Eventually they come with the node involvement, then you will be worried. So that's why address the node. Many times you address these nodes, frozen section comes as a positive, or eventually histology comes as a positive, many percentage of patients, even though clinically node negative. So type of neck dissection in MRND 1, 2, 3, rare ND. Need for adjuvant therapy and what type, whether radiotherapy or chemotherapy, what drugs, how much cycles, everything. Of course, refer to the oncology and radio-oncologist. They will take a call. Supportive care, surveillance, follow-up and surveillance. So this is the chart of multidisciplinary approach: diagnosis, evaluation, therapy, rehabilitation, surveillance, salvage treatment, palliation. Everybody is involved: oncologist, psychologist, reconstructionist, dentist, plastic surgeon, rehabilitation, feeding, nutrition, dietitian. It's a concept, it is a team approach for this patient. Everything is important to make them all right, to cure the disease and become better. So all these things are the modalities. Of course, currently immunotherapy, gene therapy also become very popular. No hormone therapy, remember. I'm not going to declare this is how exactly we take the decision. Crucial: site, location, stage, histology, node of the disease, complications, compliance, all these 5 C's. These are the important choice of treatment, remember. And neoadjuvant chemotherapy, COMSET came for 2 reasons. First, downstage, and second, for the inoperable diseases. Indication, all these things are the indications for neoadjuvant. Base of the skull involvement, teeth 4 lesions, tongue opposite side involvement. So it's very, it makes it a tumor operable, better survival, better cure rate, less recurrence. Definitely very, very useful in beyond T2 lesions, remember. So there is an entity called paramandibular lesions disease without erosion of the bone. So you can, without bone removal, without addressing the bone, we can always get away with the wide local excision if you give a neoadjuvant therapy. So give a neoadjuvant therapy to this patient because tumor is very close to the mandible, but mandible is not involved. They are called as paramandibular disease. So in such a many times you will do a marginal mandibulectomy. But give a neoadjuvant therapy, then you can save the bone mandible. That's why it is called the paramandibular disease, an entity specific. Mandible is not very close to the mandible. So noted when a patient is found to have pathological nodal disease, in general, it is recommended for adjuvant radiation that covers all levels of the neck and additional boot to the levels which are positive for metastasis. This is important. So cover not only primary area, cover the neck area. As far as radiotherapy is considered, especially number of nodes involved. When there is extranodal extension, radiotherapy is a must to the neck. That's important. That's the point. This study says that is the point. And I'm not going to discuss about that. Tumor thickness, everything takes important. Risk of nodal involvement. This diagram shows, depending on the tumor thickness or depending on the depth of invasion, it makes a lot of difference. Node, deeper the tumor, more likely to be node involvement, because depth of invasion is a crucial role, I told already. An indication for adjuvant therapy: any patient with more than one high risk feature should be considered as adjuvant therapy. All these things are nodal metastasis without extracapsular invasion, perineural invasion, lymphovascular invasion, I already told, poor difference is most important, high grade it is, close margin, depth of invasion. All these things are important. Every point is important to take a call for adjuvant therapy but interestingly, most of the patients will have one of these factors. So naturally, they land with the adjuvant radiotherapy. So adjuvant RT is most of the time is required in this patient because these criteria most of the time will have most of these patients. And external beam radiotherapy or intensity modulated radiotherapy is a good choice for surgical bed, nodal, important. Surgical bed, nodal station, this is important. These 2 points are important, remember. So this is again tumor thickness, node involvement, again just study. So all these things are the problems with the surgery, problems with the radiotherapy. I'm not going to detail it, you can read it. So many factors are there, but very important, remember. And recurrent carcinoma, it always PET CT you have to do, take a biopsy and confirm. CT area, CT chest, neck has to be done. Ideally is PET CT, but recur always most of the time. Synchronous, metachronous growth occurs after 1 year, commonly within 2 years, because remember, always MRI is very useful to assess the local area. PET CT to say that it is there is no metastatic diseases. So difficult treatment, radiotherapy already we have given, it is difficult to give. Radiotherapy second time is very difficult. Then chemotherapy, different drug regime you have to use. Then resurgery also important. Reconstruction, already reconstruction done. You got minimal reconstructive areas, no flaps, already we have done PMF flap, forehead and so on. So how to cover the area also most important, difficult many times. Concept of oligometastasis is important. Only 3 to 5 foci in 2 or less organ. This is called oligometastasis. So 40% of oral cancers, metastasis oligo, only less involvement of the distant spread, then it is called as oligometastasis. 3 to 5 foci in 2 or not lymph node, remember. 3 to 5 foci. 3 to 5 foci in 2 or less organs, if that is there, that is called oligomets. In between, intermediate, where still prognosis and quality of life better if you treat them properly. Surgery may be required in this. It's a metastatic directed treatment. All these things are important. Radiofrequency, cryoablation, radiotherapy, stereotactic radiotherapy, all these things are important. The newer concept, remember, especially postgraduate, is important. Oligomets. So follow-up, surveillance important, notes, ENE, grading, everything is prognostic factors. I'm not going to detail. I already discussed about that. Proper follow-up at regular interval, surveillance is important. So prognostic factors are already discussed. Put it in a nutshell. Stage of the disease, T3, T4 lesion, crossing the midline, nodal status, lip, anatomical location is important. Anterior growths are better prognosis than the posterior. Anterior lip is got best actually. So which has got vast posterior, which has got palate and cheek has got intermediate prognosis. So perineural invasion, angioinvasion, poor, this one, histological positive nodes. Nodes makes a lot of difference for a revival. More than 3 centimeter node and bilateral node, extracapsular node, more than 4 nodes. Tumor thickness, more than 6. Depth of most important. Exophytic growth is better than infiltrating. Already explained this. I'm just putting in a group. So take-home messages are oral cancers are very complicated disease. Lot of things are involved. Spread, crossing the midline, depth of invasion. I have given the meaning. Depth of invasion is beneath the basement membrane. Tumor thickness is from the surface, visible surface to the depth. So depth of invasion is more important than the tumor thickness. Size of the tumor, staging, number of nodes involvement, extranodal extension, and crossing the midline, weight of the skull involvement, and grading of the tumor. All these things makes a lot of difference. Remember, HPV infected oral cancer has got a better prognosis than non-HPV grows. In oropharyngeal, HPV is important. In nasopharyngeal, Epstein-Barr virus is important. All these points are important for deciding the outcome, and also for students, MCQ questions are important. Why they will ask when you present a oral cancer. Because overall, it is very common malignancy in India, 40% of malignancy. Very common in South India also. So we need to know, because day to day, very complex approach we should have to get a cure for these patients. So take-home messages are multidisciplinary approach, I already told. Depth of immunization, nodal status are the most important factors. Newer modern reconstruction methods, transoral robotic surgery better if it is available. This is the upcoming thing. SLNB currently newer thing, already told. And so very important topic, students. This is you need to understand, and all of you know, students, go through my book. Everything is there. SRB's Manual of Surgery, current edition, covers everything, whatever CBMA topics, from general surgery to specialty, urology, oral cavity, malignancy, varicose vein, and vascular diseases, breast, thyroid, gastro surgeries, everything, instruments, operative surgery, and with quotations, lot of illustrations, photos. My operative surgery book also there, clinical book, SRB clinical method surgery, with the video of examining all patients, but no treatment strategy in the clinical book, with the instruments, specimens, and operative surgeries. So, and my SRB's Surgical Insight website, YouTube, many lectures are already, more than 400 lectures are there. Daily MCQs are coming. Please go through that, subscribe my YouTube channel, and share with your friends and colleagues, and press the bell, and enjoy learning surgery by daily watching my website. And again request, subscribe my YouTube channel. Again request all students, have my book SRB's Manual of Surgery and SRB Clinical Method Surgery to learn surgery in a nutshell together, so that you will improve, you will enjoy learning surgery daily on day-to-day basis by both books as well as my website as such. So students, I hope you have understood this topic, oral cancer management, very well. Thank you so much.